Hi, I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention. By virtue of your joining this briefing, I know that you follow health policy, so you probably have read articles about the dramatic increase in the use of telehealth in 2020. Before the pandemic, about 14,000 Medicare beneficiaries received telehealth services each week. Between mid-March and early July of 2020, over 10.1 million people received Medicare telehealth services. That's a 45-fold increase. The chief medical officer of a community health plan that has long championed telehealth joked, in 1 month, the pandemic brought about a bigger increase in the use of telehealth than all of our efforts over the last 10 years combined. Telehealth made it much easier for people to access their healthcare providers. It made continuation of care possible during a time of social distancing. For some people, it provides a way around barriers such as distance, transportation, and time off work. In these ways, it opened doors to improved health equity, but it's not the answer for all people, and it did bring new equity challenges of its own. Now, telehealth is getting a lot of attention among policymakers, payers, providers, and patients. The conversations and debates center on appropriate use and future coverage for telehealth. Another issue being debated is geographic boundaries on providers. The relaxation of state licensing requirements during COVID allowed for more telemedicine, more access to care throughout the country. Will it stay that way? Today, we have 3 experts who bring different perspectives to this briefing on the state of play in telehealth and the equity challenges associated with it. Bringing the patient's perspective is Shonta Chambers, Executive Vice President of Health Equity and Community Engagement at the Patient Advocate Foundation. Barbara Hutchinson, MD, PhD, brings the provider's perspective. Dr. Hutchinson is president of Chesapeake Cardiac Care in Annapolis, Maryland. She is past president of the Association of Black Cardiologists. And Dr. Connie Hwang brings the payer's perspective. Dr. Hwang is chief medical officer and director of clinical innovation at the Alliance of Community Health Plans. Each of these speakers has an extensive and impressive background that makes her superbly qualified to brief us on equity issues in telehealth. Their bio sketches are on the webpage for today's briefing. I commend them to your attention. Before the briefing gets underway, a few words about the Value and Innovation Forum. The Value and Innovation Forum is a collaboration of the National Forum for Heart Disease and Stroke Prevention and Patient Advocate Foundation, both 501c3 nonprofit organizations. Briefing topics are selected by the Value and Innovation Forum Steering Committee, which includes representatives of the Alliance of Community Health Plans, Association of Black Cardiologists, Caregiver Action Network, and National Osteoporosis Foundation, in addition to the National Forum and Patient Advocate Foundation. Briefings are made possible by funding from Amgen, in accordance with the National Forum's policy on corporate and foundation support and relationships. This policy ensures transparency and integrity in the National Forum's dealings with sponsors. Now, a little housekeeping. First, this briefing is being recorded. You will receive notification from the National Forum when it is posted, along with the briefing summary and speaker resources. Second, please submit your questions using the Q&A button. Third, if you have comments or information to add, please use the chat function. Finally, at the end of today's webinar, a survey will pop up. Please share your input with us. Now I invite Shonta Chambers to give a brief overview of telehealth issues from the patient's perspective. She will be followed by Drs. Hutchinson and Hwang, and then we will have questions and discussion. Ms. Chambers?
So good afternoon, and thanks so much, John. I am delighted to be with all of you today, along with my esteemed fellow panelists. For over 25 years, Patient Advocate Foundation has been at the nexus of addressing access, affordability, and quality barriers for patients living with chronic and complex health conditions. The convergence in 2020 of telehealth provided some resolutions to challenges related to access to care. However, we must also acknowledge the potential risks to quality. We also cannot lose sight of the barriers that this model of healthcare delivery may pose for limited resource populations, seniors, those living in technology disparate communities, and others. However, we also have the unique opportunity to look closely in how the use of telehealth can broaden our ability to address social need gaps in a way that we've never been able to do it before or we found to be most difficult. I think it's always important to lead a conversation with definitions. So, in the context of telehealth, it's important to set this framing because telehealth and telemedicine are often used interchangeably. And like many other things within the context of healthcare, when we use them interchangeably, they confuse patients. So, telehealth, when we think more broadly of this definition, it refers broadly to electronic and telecommunication technologies and services used to provide care and services at a distance. Telemedicine is the practice of medicine using technology to deliver care at a distance. Telehealth is different from telemedicine in that it refers to this broader scope of actual remote healthcare services than telemedicine, which is solely clinical. So now we've kind of set the foundation with some definitions. So when we look at telehealth through the eyes of patients and with a commitment to patient-centered care, there are some barriers that we must take into consideration to help ensure that our use of technology does not unintentionally broaden healthcare disparities or exacerbate inequities. These are barriers that we must consider, along with understanding that each of these barriers is not experienced in the same way by everyone. The impact of these barriers will vary by age, by race, by ethnicity, by geography, and also by socioeconomic status. One of our national patient advocate volunteers and patient advisors says it this way: we are starting in the context of telehealth. We are starting with the assumption that people have the equipment. That's just basic. That's just fundamental, right? Because if you don't have the equipment, then we've made, again, something available, but not accessible. So what are some of these barriers that I mentioned that I'm thinking of? So if we start with lack of access to technology, we have to understand that honestly, access to technology is a privilege. And it is a privilege that is not experienced by all individuals in the same way. We also have to account, for many years, we've been talking about health literacy. And now with this conversion of telehealth, we also have to bring in this new phrasing around digital literacy, understanding that now you have maybe an absence of health literacy coupled with some limited digital literacy. So how does that really impact one's ability to be able to engage in this new innovative approach to health called telehealth? Also, lack of access to broadband and internet, including internet, broadband, and bandwidth speeds in rural or underlying areas. I caution us to not only think that this is an issue of rural America and rural communities, because there are many urban communities that have these limited bandwidth speed situations, as well as limited access to technology. We really saw this play out in the education session when all of our students had to go to these virtual learning environments. We really began to see that we don't have the bandwidth infrastructure that we really thought, even within our urban communities. And we know that there's a preference. Some people truly do prefer in-person visits. Then we begin to look at lack of access to data. So we talk about telehealth with the realization that if we start with that question around, we assume that everyone has the equipment. What about our seniors who still are holding true to that 1999 or early 2000 flip phone that doesn't have those same capacities as some of our smartphones? And for those of us who are at a point where we do have our smartphone, we have to ask ourselves, is my data plan sufficient to allow me to be able to actively participate in a telehealth encounter? Or if my plan is sufficient, with that one visit, it completely exhausts what my data plan allowance is for the month. There's a consequence to that. There's a cost for that for patients, and we have to keep that front in mind. We also have to think about issues of trust. So historically, we've always talked about trust in the provider-patient relationship and how communication is so critically important to that relationship. So now we've added this apparatus, whether it's a telephone, whether it's a iPad or smartphone, we've now brought another apparatus into this equation, and it's no longer just a direct patient provider relationship. Now we now have this external apparatus that we're now using. So we have to understand, how do we build upon and expand trust in this technology driven environment? And we also have to understand the potential hazards of this impersonal interaction, because it's not maybe that warm and fuzzy that we sometimes get in that direct in-person encounter. So use some of these barriers, but I'm the person that always believes that the cup is half full and not necessarily half empty. If we begin to focus on the broader definition of telehealth, what it affords us is also this unique opportunity to identify and address social need gaps that may hinder one's ability to actively engage in their healthcare experience. For Patient Advocate Foundation, audio or telephonic communication is the bedrock of how we connect with individuals to assess and respond to social need gaps. For example, during the COVID-19 pandemic, the use of audio technology allowed us to assess for and respond to food insecurity needs for over 20,000 individuals, resulting in an allocation in over $10 million in food assistance grants, thanks to the generous support of the Bristol Myers Squibb Foundation. Cumulatively, though, audio technology allowed us to address the social needs and financial needs of more than 177,000 individuals. And digital technology allowed us to reach an additional 15K. So total almost 200,000 people as an organization we were able to reach by using the technology that's available to us. If we allow ourselves to think broader about the broader context of what telehealth affords us, there is so much opportunity before us to take a more comprehensive approach to healthcare delivery. Telehealth provides the opportunity for these strategic opportunities to address the social determinants of health by identifying specific social need gaps caused by them. Yes, telehealth creates these opportunities for innovation, but we also have to understand that in order for all individuals to be able to access healthcare in a way that responds to their very unique needs and responds to what's most important to them, we have to be strategic in understanding what is needed to help elevate them into the telehealth enterprise.
Thank you, Shonta. And now Dr. Hutchinson.
Thank you. And thanks to my fellow panelists. It's just a delight being here today. The challenges during the telehealth challenges during the pandemic were real. I will begin by sharing my story. At the beginning of 2020, my big, hairy goal for my practice was to finalize selection of a telemedicine platform, which I had been researching for at least 2 years. Because I thought by introducing telemedicine to my patient population, it would improve the patient experience, especially for those patients that traveled several hours to see me. I also thought it would help in the management of chronic diseases such as heart failure, high blood pressure, and diabetes. I located possible origination sites, which at the time was needed to be able to bill for these services. The cost of some systems were prohibitive. I finalized on a product in early March of 2020, but never in my wildest dream did I know that 2 weeks later, I would be plunged into using it on a daily basis because of a pandemic with stay-at-home orders. I left on Friday seeing patients in the office, and by Monday, I switched to all video visits because there was a stay-at-home order in my state. In selecting a system, several things were important to me. One was, a big one, was the ease of use to the patient. I wanted to be sure the patient did not have a lot of downloading, just a click of a button, and they should be able to see me and I should be able to see them. The second thing that was important was access to the patient by either a phone or email. During the pandemic, several challenges surfaced that I did not anticipate. Number one, looking first at access. Up to 60% of my patients that were over 65 years old did not have access to a smartphone, a tablet, a computer with internet access. And for those patients that had a smartphone, tablets, a computer, they did not have consistent internet service in the areas that they lived. So during our conversation, our connection would be interrupted several times during the visit. Then there were those that had all the technology, yet they were afraid to use it as a way of communicating with their doctor. They preferred an in-person visit where I can see and I can touch them. They did not consider a video visit or talk on the telephone as a visit. I see several patients that are either mentally challenged, and as you could well imagine, coordinating a video visit in a location with a sign language interpreter was a challenge. Early in the pandemic, they were not seen because many of the appropriate masks for the interpreters were not available where they could see their lips so that they could lip read. Similarly, for the hearing impaired, using a combination of a video and telephone assisted call system required a lot more coordination. And so several of these patients early in the pandemic were missed. How about the quality? When you think of a video visit, and of course, later in the pandemic, we were very pleased to learn that now visits could be audio. Effective telehealth or telemedicine, we know, can prevent unnecessary visits to emergency room by catching and intervening early on medical issues. But for many of the patients that I care for with chronic diseases like high blood pressure, diabetes, congestive heart failure, I realized during the pandemic, they did not have the tools at home to really help in their management. What do I mean? For example, patients with a long history of high blood pressure did not have a blood pressure monitor at home. Those with congestive heart failure did not have a scale. Those with diabetes did not always have a glucose monitor so that they can test what their sugars were. I realized how many patients were dependent on office visits for measurements of their vital signs. And so very early, I started writing prescriptions actually for these monitors, such that patients with these chronic diseases could have these tools available at home. So when they were called, they had the necessary data ready for their physician. How about security? Many with smartphones were used to Skype and FaceTime, and they could not understand why this could not be used to communicate with them. It was difficult communicating the importance of HIPAA and it seemed real difficult for especially some of my older patients. How about privacy? In communicating with patients, for me, I chose to see all patients in my office where I can close the door. I was in my white coat just as they would see me in the office. At home, patients I saw, I often ask first if they can speak, were they in a quiet room? And often I could hear noise in the back. There may be children running around, but often that privacy was was not often present. The examination, initially, I had to get used to not using my stethoscope to listen to a lung and a heart. I used my eyes to examine necks, the hands, the legs. I will have them scan down to their legs. Was there swelling? No swelling. I had the patients assist me in checking all these things. Do you have pain? My biggest frustration was that patients with significant high blood pressure not having the tools that we talked about earlier. Also, patients who had arrhythmias. My concern was, are they having that arrhythmia now? Are they in? I had to depend on the blood pressure and the heart rate. How about affordability? Many patients realized that in order not to be left behind, they needed to have all these smart tools, a smartphone, blood pressure monitors, pulse oximeters, glucose monitors, a scale, a monitor for their heart rhythm. But many could not afford these items. How about the affordability on the physician side? Many of the physician equipment was not very inexpensive, it was very expensive. And so, especially during COVID, where you had a decrease overall patient visit, many physicians at the beginning could not have afforded the system. I was fortunate in the sense that I had identified and selected a system before the pandemic. And so these are just a few of the things that I experienced, and I would be happy to elaborate more during a question and answer period. Thank you.
Thank you, Dr. Hutchinson. Now, Dr. Hwang.
John, thanks so much. And it really is a pleasure to be on this telehealth panel today, adding to the important perspectives of the patient and the provider shared by Shonta and Dr. Hutchinson. So before I share some observations from the payer perspective, I'd like to offer some background on the Alliance of Community Health Plans. Oh, fantastic. I see the slides coming up. So ACHP is an association of nonprofit, regionally based community health plans that provide coverage and care for over 22 million Americans. And our footprint is across 36 states and Washington, D.C. The kinds of health plans that ACHP members represent include integrated care delivery systems or community health plans with longstanding ties to the local provider network. It's really this primacy of the payer-provider model of care that brings organizations like Kaiser Permanente, Health Partners, UPMC, and Independent Health together at ACHP. If we could flip to the next slide, Jen, that'd be great. Thank you. So I think you've heard through our other panelists and also John's introduction, I think it's widely reported about the unprecedented growth in telehealth that we all experienced in the past year. So CMS indeed reported an 11,000% increase in virtual visits in 2020. And as you can see on this slide, we saw similar 1,000 percentage point jumps in our own ACHP member health plans. So through this increased utilization of telehealth, I think I want to highlight three major themes that I think we've seen emerge in this landscape. And the first one is the pandemic really has reshaped expectations for telehealth, where there is broader recognition of its convenience and affordability. So under the public health emergency, new flexibilities were granted to telehealth so that it could be utilized more conveniently in places like the home setting or outside of a rural designation. And also under the public health emergency, the types of providers who are able to offer telehealth services expanded. Things, areas like occupational therapy, behavioral health specialists in some spaces, physical therapy, et cetera. And so from that perspective, in addition to these flexibilities, I think from the viewpoint of affordability, many health plans jumped in to reduce or eliminate copays for telehealth visits, really trying to free up that access to this tool. Savings on indirect medical costs, when you think about telehealth versus face-to-face visits, can be quite sizable. So the RWJ Foundation and Avalier a couple years back studied inner city Chicago prenatal care for women who were taking the bus to their regular doctor's appointments. And so when you think about things like transportation, childcare, lost wages from time away from work, when they quantified that all, it was on average about $2,600 for 9 months. And so that's really not an insignificant amount. That's really coming out of pocket just to do face-to-face visits. I think a second theme for us that we've seen, kind of a silver lining, I guess, to the pandemic story with telehealth is really related to greater access to mental and behavioral health. So again, one of these notable trends is that, interestingly, when the pandemic started, a lot of behavioral health leaders noted that no-show rates actually dropped significantly. So with the folks that are keeping kept appointments, actually much higher than pre-pandemic. And interestingly, as the pandemic has, as we're now at a point where we're sort of reemerging, face-to-face visits have increased for a lot of clinical office visits. But interestingly, for behavioral health and mental health, it's actually stayed kind of high for telehealth. And so remains high. And I think that gives you a sense of the type of access, maybe avoidance of stigma, the convenience that folks are seeing in that space. A lot of our plans actually partnered with different groups to expand telepsychiatry, and it really has helped to relieve the backlog in some high demand mental and behavioral health spaces. Think child psychiatrists, oftentimes there are long waiting lists for that, or we're looking for more niche areas like therapists that are experienced with LGBTQ youth, for example. So trying to widen that net through the use of telepsychiatry, it has been quite promising. And I would say like the third theme that we've seen in conversations with our ACHP members is a commitment to bridge this digital divide. So ACHP members and our health plans want to avoid perpetuating existing health inequities. And to do this, there is a focus on two strategic areas. The first, and again, both Dr. Hutchinson and Shonta sort of mentioned this, tech barriers, right? So how do we try to ensure that there is reliable broadband service? That individuals have access to smartphones, tablets, et cetera. So there's sort of that one area of focus. The second is really about digital literacy and really trying to increase comfort level with devices and technology and making sure that such programs and services are offered in a way that are culturally appropriate and offer adequate language support, et cetera. So hopefully later on in our discussion, we can go through a couple examples of certainly where health plans, such as members of ACHP, are really focusing not only in technical investments, but the idea of developing necessary playbooks and capabilities to really get both patients and providers really comfortable with this modality. Next slide, please. So I just want to conclude that there's an adage that's been circulating when you think about telehealth post, with the pandemic. But never let a crisis go to waste. So ACHP's policy and advocacy team are really quite active in conversations to retain important telehealth flexibilities that have been granted under the public health emergency. So these are things like, again, keeping things flexible in terms of the site of care, home setting, outside of rural designation, trying to allow different provider groups to be able to provide these services and bill for services. We also are very interested in furthering the impact for mental health and provision of that, given some of the notable successes. Really, there are some good opportunities when you think about substance use disorder, recovery programs, how to really expand access to medication-assisted therapies. And always in these discussions, like with any modality, trying to move to a much more value-based model, I think allows for an environment of greater innovation. And also, we don't want to, get into a space where you're trying to figure out how to bill for every phone call, et cetera. I think we want to move to a direction where any of these modalities, be it audio, be it video, you want to use them at the right time, in the right places, and essentially get paid for the outcomes that you're generating. So just a couple of mentions here. There are some good recommendations from MedPAC on telehealth that ACHP is throwing its weight behind. Again, trying to extend some of these public health emergency flexibilities, lifting geographic restrictions, trying to move towards value. And again, there's some legislation being proposed called the Connect for Health Act, which is trying to push on CMMI to do some interesting models for telehealth, and also to give HHS some more authority over telehealth waivers outside of a public health emergency setting. All this in the end is to try and help us improve affordability, access, and health equity when we think about this important virtual care telehealth modality. So with that, John, I'm excited for the conversation ahead, and I want to turn it back over to you.
Well, thank you, all three of you. Those were great overviews that you provided from different perspectives, very helpful. I heard a number of things. I know I was busy taking notes. I love Connie, the axiom, never let a crisis go to waste. And Shonta, your comment that available does not equal accessible, I think is a very important reminder for all of us. And then all three of you, I heard talking about trust in care and in the patient-provider relationship from different angles, all of which clearly are very important. So thank you so much for your comments. Dr. Hutchinson, you talked about the difficulty that patients have with care when the person with hypertension doesn't have a blood pressure monitor at home, or the person with heart failure doesn't have a scale, or the diabetes patient doesn't have a glucose monitor. And I love that you wrote prescriptions for those devices. Were the scripts filled? Do you have a sense of that? And do you know, were any of them covered?
Well, that's a great question, and I've found out that some of them, when they took the script to the pharmacy told them it wasn't covered and they had to pay out of pocket, and those who did not have the money did not have it. And that's another thing that I think that's basic across all insurances. These are basic tools for chronic care management. And those are the tools, if we want patient to be a part of their care, that's the least we can do. Have them have the basic tools at home, an automatic blood pressure monitor. Everyone who has a diagnosis of high blood pressure, their insurance company should pay for that. It could be, they pay for it every 5 years or whatever, because these machines, they shouldn't break every day. So it's not like once a month you need it, not like a pill. But I think that should be part of the armamentarium, just like you have a card for all the insurance company, you have access to these basic tools for diabetes, a glucose monitor, an attester, blood pressure monitor. If you have any kind of chronic arrhythmias, being able to have access to that.
And Dr. Hutchinson, you're mentioning these things in the context of telehealth, but aren't these barriers, aren't these challenges that you and your patients face with not having these devices? Doesn't that affect the quality of care in, let's say, a normal environment?
It does, because in the case of COVID, when I called and you did not have these measurements, let's say, and you're on high blood pressure, my assumption was that your blood pressure is controlled. And sometimes that assumption may have been incorrect, because a week later or a month later, the person showed up in the hospital with a stroke, which meant that during that period of time, it really wasn't controlled. So I think it's very important. That was one of my biggest pet peeve during COVID, when I realized how many people. Now I'm fortunate because I've said it so many times. Now when I call the patients, and this is like 1 year later, those doing virtual, they have ready for me blood pressure, heart rate, they have the SATs, they have their temperature, because they've now gone out or had friends donate these items to them, because I emphasized how important it is. So I'm fortunate now that I would say 80% of the patients that I call now have those numbers for me.
Wow, that's terrific. Dr. Hwang, I know that some carriers or some plans do cover at least some of the devices that Dr. Hutchinson mentioned. What we have patient advocates, we have provider advocates, we have public health advocates who are listening to your comments now. What can they do to help bring coverage for these essential tools for care to more people?
Yeah, well, and I'm excited to hear from Dr. Hutchinson's perspective that more and more patients are proactive, identifying ways to get these tools. I would say from a lot of ACHP member plans, particularly those who have really leaned in on a telehealth strategy, making sure that you have these basic biometric tools, oftentimes Bluetooth enabled in these programs, that's kind of like table stakes, right? Where there's a lot of investment in that space. I think, to your question, John, the more that a consumer, patients, families are saying, hey, this is a way I am comfortable and want to receive care for the convenience and affordability, we want to do this and we want to do this in the long term, I think that just makes a case for itself to say, great, we need to provide greater access to these tools because in the end, it's going to lead to better healthcare and better care, better health, and hopefully, again, lower costs because you avoid, outcomes that could lead to hospitalization and emergency room visits. I would want to add a few things about how health plans are thinking about technology and understanding what the needs are out there. But a lot of our plans, again, those that are focused on telehealth programs, maybe things that have remote patient monitoring, many are leveraging community health workers in working with, a variety of populations, usually those with chronic disease, but they've come up with assessments and conversations. And we had a panel actually at ACHP probably about a half a year ago where some community health workers were able to share some perspectives, in terms of best practices, which include things like don't make any assumptions about what kind of equipment, anybody has access to, what they're using and what they feel comfortable with. Always ask about what's the best way that they learn, how do they want to, move forward. Consider affordability for members. Many actually are behind on internet service payments potentially, and that even a $25 phone, not even a smartphone, can be an issue. So many, again, these programs are trying to upfront do these assessments. One interesting example from our member plan that has a very, broad, telehealth program has this story where they had early on in their experience, they had identified this patient. She met chronic condition criteria, they're setting her up with palliative care. They wanted remote patient monitoring, do some video check-ins, this would be great. And then she ended the conversation with, no problem, I'm just going to have to ask my neighbor if I can use the electric, outlets in her trailer to charge all the devices, but then we're good to go. So for them, it was like this aha moment of, okay, we've got to reverse things, assess a lot of these things up front, help provide the services and the tools that are necessary. But it's a learning process. And again, the pandemic has really turbocharged that, right? And I think as we move forward, there really is this acknowledgement about let's understand better what that landscape is in terms of tech and how can we support that.
Wow. Great story. Thank you for those suggestions. Shonta, the Patient Advocate Foundation is on the front lines assisting patients, helping patients who are facing barriers to care, whether it's in a normal environment or telehealth. How have you all been able to help patients surmount some of these barriers that Dr. Hutchinson identified, such as the lack of equipment to track vital signs at home, or what Connie mentioned, even upstream things such as having electricity. I mean, you know, when Dr. Hwang said that, that really reminded me of a comment I heard a physician say in an interview last summer, who said that while there's some difficulty with the distance created by telehealth, that it also greatly enhanced his ability to understand the patient's environment and the realities that they face in implementing his care regimen or his recommendations in their everyday lives. So I'm guessing, Shonta, that there are two sides to this coin, and I'm wondering how you've helped patients to, on the one hand, take advantage where possible, and then on the other hand, to overcome some of the barriers that Doctors Hwang and Hutchinson have identified.
So John, first of all, I think it's no longer a coin. I think it is some type of prism, because every time you flip it over, there is something different that is discovered. And I appreciate Dr. Hutchins raising the fact that, well, I started out with a comment from one of our volunteers about us assuming that people have the equipment. And I think the first fundamental mistake we made was the assumption that the only equipment that someone would need to be able to participate in telehealth was some type of communication device, whether it be a phone, a laptop, or what have you. But as Dr. Hutchins pointed out, that's not the only equipment they need, contingent upon what their condition is, what they need. Like she pointed out, blood pressure monitor, glucose, pulse ox, all of those things. So it makes us peel this onion back and say, even when we start to look at equipment, the elements of what defines equipment and qualifies as the equipment that ones need to respond to their very unique situation can be as diverse as the individual. And consequently, the cost associated with them to be able to participate in a telehealth visit goes very beyond what we talked about. So, the provisions waive copays, right? So waiving a copay may be one thing, but if I need all of these other things that I already can't afford, then yes, the waiving of a copay was just a tip of that iceberg. So I think thinking about it in the context of that. And so that is some of what we hear from patients. And so yes, it's about helping them to identify the financial resources to address some of those things that Dr. Hutchins pointed out. But we also have to acknowledge that as a result of the pandemic, we also saw an increase in those individuals who are now uninsured. So we've been talking in the context of folks who have insurance, but now we have to think about all of those individuals who are now uninsured, but we want to ask ourselves, how are they now engaging with the healthcare system, or are they completely not engaging? We know that those who are uninsured don't engage when there's an in-person interaction. So we really have to ask ourselves now, for those who are uninsured, what is happening in terms of their health? Because they're not accessing, they're not engaging because they're uninsured. They don't have access to the resources for any of the things that we've talked about today. Many of the patients that we're talking about, they're trying to satisfy their basic Maslow's hierarchy of need, food, water, and shelter. So we're helping them identify and connect the resources to address those things. And so we think in a normal situation where health gets pushed down on the priority list, we really have to ask ourselves, where is it now in the context of this kind of post-pandemic environment where we're going to find ourselves? And so as we think about telehealth, that's why I pointed out we have to really center this around the social determinants of health and the social needs that are actually exacerbated. That is what we see playing out, an exacerbation of unaddressed social needs. So we're talking about things like transportation and healthcare. One of the most critical things that I think also I heard in Dr. Hutchinson's comment, as well as Dr. Hwang, we have to acknowledge that in this post-COVID environment, and I'm using it thinking futuristic, many of the social networks that people used to rely on are no longer there. So for that senior who cannot connect on their own, They can't call their niece, their granddaughter, or go to their neighbor to help them. Use a perfect example. My father is 83 years old. Unfortunately, he ended up being diagnosed with COVID and subsequently had a stroke while in the hospital. All of his post-release care, discharge care was done via telehealth. Now, he's 83. He doesn't know what a computer looks like. He wondered how we were able to do any of all the stuff we do with these phones. But every single visit he had was a telehealth visit. Because I'm his caregiver, no, I had a blood pressure monitor at home. I had a pulse op because I know. But if I were not available to him, if I could not be there to support him in his encounter, he would not have been able to adhere to the course of care that his healthcare provider had provided for him. Not only was the technology or the equipment not there, the social network that he needed to help support him in engaging and connecting, even if he had the equipment, was also absent. So Connie pointed out, we have to take into account the social context in which health takes place, and it is outside of the four walls of the healthcare system. I think this telehealth environment has really forced us to understand that yes, it is outside of the four walls of the healthcare system, and social context matters. So how do we leverage this broader understanding of telehealth to also bring into the conversation responses to these social needs that are also identified?
So what I'm hearing in that answer, Shonta, and really from all three of you, is that in some ways, telehealth enables people to overcome some barriers, time off from work in order to get care, have an appointment with a provider, um, transportation, affordability, things like that. On the other hand, there are new challenges that come with it. And so I'm wondering, as I'm listening to the three of you, whether going forward in the post-pandemic environment, we'll be looking at a different paradigm for the delivery or provision of healthcare going forward, and it won't have some integration of telehealth into the model. What can each of you, in maybe 60 seconds each, describe what you see healthcare looking like in the future, and what would be sort of an ideal model and use of telehealth? And then perhaps as a follow-up, we can talk briefly about what action people participating in this briefing today can take to help make that better reality possible.
Mm. I'll start. I think going forward, it's going to be a hybrid model. Patients would be able to see physicians in the office or virtually. If we're going to see patients virtually, I think we have to realize that for some patients, they're cared for by a village. We assume that it's always just a one-on-one. And so even with the technology, which has really been helpful to me, I like the technology I have. I can talk to the patient plus two other people, up to three other people, because that's what reality is like. It's a village that takes care of them. They may have a daughter out of state that wants to know what's going on, one locally. And if you can bring everybody into that conversation, everybody feels involved and feels that their loved one is really being taken care of, although it's in a virtual environment.
Great. Thank you, Dr. Hutchinson. Dr. Hwang?
Yeah, I would love to build on Dr. Hutchinson's vision that way for this hybrid model moving forward. So many of our ACHP member plans, but health plans, a lot of them, in general, have been investing in this technology. Now, again, the pandemic has really, accelerated that by a number of years, which is great. So I think that the challenge ahead is, how do we find that right balance where telehealth is really supporting us in generating high value care? Right. And there are many, many opportunities for this, and actually a lot of knowledge already so far. But I want to build on this whole concept of as Dr. Hutchinson mentioned, is sort of the village, right? It takes sort of the whole infrastructure and environment to be, committed to expanding this. And so one of our members, Kaiser Permanente, who has been a strong leader in telehealth for really better part of a decade of investment in this, one of their leaders, again, in one of our meetings, mentioned that telehealth can't just be a Kaiser Permanente or health plan solution. It has to really be a medical community or neighborhood type of solution. So I want to mention sort of a news brief that they had, but back in March, Kaiser Permanente awarded $2.37 million to 59 safety net organizations across the country to advance virtual care and telehealth for low-income communities. So it's a mix of public hospitals, FQHCs, other healthcare organizations that really provide low-cost or free subsidized health services. And the idea is to have these grants really help these organizations expand telehealth infrastructure and provide accessible services to people, especially in these neighborhoods where they're experiencing greatest health inequities. So that's one way. Again, we know it's not just the health plan solution, it's really outside and really bolstering that in the overall environment. I think another thing I want to mention in terms of the future, some of our ACHP member plans, given sort of what the pandemic has shaped in terms of expectations on telehealth, are innovating in terms of products where if you do have the option for insurance, you could potentially choose a product where it's telehealth first, right? Where your first thing is not to go into an office, but actually engage with a telehealth provider. And if individuals who enroll in that will get a kit sent to their house of exactly blood pressure cuff, thermometers. It'll be tailored to kind of the chronic conditions that may be present, for that individual. And what's interesting is these products, actually, there's 3 of our plans that are piloting, or not even piloting, they're experimenting with this and launching that. It's Kaiser Permanente, Harvard Pilgrim Healthcare, and Priority Health. They have versions of this where those products are up to 20% more affordable in terms of premiums. So there are, again, this may not be for everyone, but just trying to show you that landscape is shifting. In terms of what people may be accustomed to, where there could be some efficiencies, where there could be, again, opportunities where this will fit, for, a particular household and their budgets. And the last thing I want to mention, a good example for one of our plans, Marshfield Clinic and their health plan, Security Health Plan up in Wisconsin, they recognize, again, not only is there tech, but there's that whole digital literacy, the comfort with that. So one of the things I thought was really interesting, again, it takes a village, that they've created these telehealth, remote patient monitoring training sessions and workshops to actually, for those that are interested, a lot of them tend to be seniors out in these rural communities wanting to learn how to use some of these smartphones, tablets, devices, et cetera. And they get high school volunteers actually to do some of these trainings. So it's interesting how to bring a lot of these forces together as we're trying to work on both that tech and that digital literacy aspect there.
That's great. And I love the real life examples. Thank you, Dr. Hwang. Shonta, the Patient Advocate Foundation perspective.
So I would definitely encourage us to really think about what person-centered telehealth really looks like. And what that really begins with is addressing people's needs as they describe them, as the patient describes them. And then the other part is probing when they don't. Because oftentimes in this telehealth environment, what you will find is an individual may not tell you that they don't have access to the technology, or I have a cutoff notice in my mailbox, and so I won't be able to do these things. So it's about being positioned to assess for these things. And so it's really about making sure that everyone is assessed for their information and technology capacity and their support needs, and then coupling that with guidance around how they connect to these types of resources. This is not only how we help to build health literacy, but this is also how we help patients to prepare for these telehealth visits in a way that they become mutually beneficial, because at the end of the day, it's about healthcare delivery is about the benefit to the patient. And so we have to think of this through a patient-centered telehealth lens.
Great. That's a great framing. We're down to our last 2 minutes, and so I'd like to ask each of you, as all these policy discussions are taking place around us, again, for the participants in the briefing, can you identify one, or if it's really quick, two policies that you would say are essential to getting to better, improved healthcare and better outcomes on the other side? What's the one policy that advocates should go to the mat to obtain in discussions with policymakers? Shonta?
So I would start with improving insurance benefits to cover telehealth service, including audio-only coverage policies, because that affords some mitigation to some of these barriers that we talked about in terms of bandwidth if we can do audio only. Along with that is also the integration for assessing for social needs. So I would say improve insurance benefit design to cover audio only and the integration of social needs assessment.
All right, Dr. Hwang.
Yeah, I like what Shonta said on audio only. Again, our experience at the member health plans, telehealth is a spectrum of tools. And sometimes when the video connection is off, you flip to the phone. I mean, why would that be not allowed? Like it's in your spectrum of tools. So we're fans of that. We think there's a lot of good information and value in permitting that. I think I'll just go back to kind of what we had mentioned earlier on one of my slides, but it's really to make those flexibilities that we've seen in the public health emergency permanent, right? People should be able to access telehealth from the comfort of their own home. You should not have to be in a rural designation. I also think allowing more broader sort of licensure where, you could have care from a physician that's one state over, but it's via video and phone. I mean, I think anything that helps to increase access and convenience and the types of providers that can offer telehealth, I think we need to make those permanent. And then the other second thing you said, there's two things. We really do need to use this opportunity to move towards value-based payment. We're never going to win the affordability, sustainability, challenge if we keep paying for widgets, right? If we keep paying for every single phone call, every single email, that doesn't make any sense. We've got to move to something where you're paying more globally and use these tools to, at the right time, the right place. As Shonta said, it has to be patient-centric. That is what we should be spending some of our time thinking about as we look at the future of telehealth. Really, what kind of payment innovations can we put in place there?
Thank you, Dr. Hwang. Dr. Hutchinson, I'm going to throw you a curveball here because we have a question from Dr. Sunita Dodani. She leads the Healthcare Analytics and Delivery Science Institute in Norfolk, Virginia, which is a partnership between Centera and Eastern Virginia Medical School. She says, COVID has hit the vulnerable, the most rural areas and disparate groups. These are also the ones who have low literacy and poor access. Available data says that telehealth is least used in these groups. We have a COVID registry looking into the impact of COVID on mental health, and the numbers are astonishing. What would you advise on how we can improve telehealth in these pockets and improve equity?
That's a great question, and I think it's a real one. And I think in these pockets, because of some of the things we've heard about it, maybe bandwidth issues. But I think as I think about it, one thing that could help is if we have like a community approach, because in these pockets, there may be churches or schools that have these communication, have internet service where the patients can go to be able to access it now that it's opening up a little bit more. So that's one option, having a more community approach. If there's one place that has internet where people can go and access and see the doctors there, that would be one thought. A little.
That's great. Thank you. Pardon me?
I said a little out of the box.
Out of the box is where we need to be, or where we need to go.
Yeah.
Well, thank you very much, Ms. Chambers, Dr. Hutchinson, and Dr. Hwang for sharing your knowledge and insights on telehealth and health equity. I wish we had another half hour or hour because your insights are so valuable. I want also to thank Amgen for sponsoring the Value and Innovation Forum and making this briefing possible. A reminder to you that a survey will pop up on your screen please take a moment to fill it out before you leave. Your feedback is important to the steering committee, and your input will help us bring relevant and useful issues briefings to you in the future. Finally, the speakers and the National Forum have gathered articles, infographics, and other materials on telehealth and health equity, and those materials are available now on the briefing webpage, and the URL for that page appears on your screen right now. With that, thank you again for joining the Value and Innovation Forum briefing today. We are adjourned.